Before I start, I'd like to disclose I am a paid advisor for Pure Encapsulations and that I have no other conflicts of interest to disclose. So tonight I'm going to be talking about the function of folate and B vitamins in the body and touch on the essential roles that folate and B vitamins play in relation to preconception care, hormone balance, healthy aging, and I'll bring in a little bit of the mental health aspect as well. I'll talk about the different forms of folate and B12 supplements, and we'll talk about some of the dosages and evidence that currently is out there. So folate and B vitamins are key nutrients required, and I'm going to move this. I wanted to see all of your lovely faces and names, and I made this really big and now I can't see the slide. I'm just going to move that up there. Required to act as substrates and cofactors to support DNA synthesis and methylation processes throughout the body. So what does that mean? It just means that folate and Bs are required in metabolic pathways. When I say cofactors and substrates, you will see an example of that. I'll show you the metabolic pathway to help make the basis for our DNA and methylation, which we'll also discuss a little bit further. This is really important for fertility. So when you think that a sperm and an egg need to come together and they have to replicate into hundreds, thousands, millions, billions of cells to form a baby, obviously we need our DNA to be replicating. We obviously need folate, but also methylation is really important because of what's known as differentiation. So gene expression, we need methyl groups to sit on the DNA, suppressing genes that should not be turned on, because actually in every single cell in the body, you have your entire genome, all of your DNA, but only certain genes are turned on. If it's behaving like a liver cell or a pancreas, will only turn on the gene for insulin, etc. So methylation is really important for that, the gene expression side. In addition, folate and Bs that support methylation are required for hormone balance, specifically in relation to estrogens. So for those of you that do work in the hormonal health space, in women's health, you would know that estrogens get metabolized into particular metabolites. They then have to go through either methylation, sulfation, or glucuronidation pathways to excrete and get rid of those estrogen metabolites. So methylation is key there. Also energy production, methylation is needed for creatine, brain health, so for regulating homocysteine, which can affect our endothelial cells, causing vascular damage that can impact cardiovascular disease, as well as neurological conditions. So that's not everything, but they are big things that are directly associated with folate and B vitamins. So it's really important to ensure that our patients, whether it's for preconception, hormonal related things, healthy aging, cardiovascular health, mental health. So, when we talk about mental health, neurotransmitters are regulated through methylation as well. So making sure that we have enough folate and B so that all of these processes in the body are functioning and our patients and ourselves are well. So here is a simplified version of a methylation pathway. So I publish it here as the 1-carbon metabolic pathway. So 1-carbon is the same as methylation because a methyl group is basically a group with just 1 carbon and 3 hydrogens. So this is the methylation pathway. It can also just be called the folate B vitamin metabolic pathway. So what you can see in this pathway, and you don't have to understand in great detail, but you can see up here at the top, I'm not sure if you can see my cursor there. If you can, hopefully you can, but if you can't, whoops, when I click it, it goes to the next slide. But folic acid is up in the top right. So this is where folic acid enters the pathway. We've got dietary folate down the bottom, which enters as 5-methyl. So when you eat food, most of the folate is in the methyl form. Not all of it, but most of it. And this is actually the predominant form. This 5-methyl down the bottom is the predominant form in our blood. So over 70% of the folate circulating in our body is the 5-methyl. So basically we have folate coming in and it gets converted to different forms of folate. It picks up methyl groups. There's an enzyme here that requires B6. And folate can either be directed over towards the right, and that is for DNA synthesis, or folate can come either via MTHFR or directly if you're supplementing with 5-methyl or eating folate-rich foods, come in as 5-methyl, and this is the folate that donates a methyl group to homocysteine. So sort of jumping over here. So this methyl group, it comes off, it's attached to homocysteine to make methionine, and then what comes from that? Can people see my mouse as I'm doing things? Sharon, I can see you. Can you give me a thumbs up if you can see my mouse on the screen? Can you see my mouse on the screen?
Yes, we can see it. We can see it, Denise.
Great, good, because I'm saying this, I'm thinking if you can't follow me here, you could be totally lost. Thank you, Denise, and thank you, Sharon. So yeah, the 5-methyl, once it donates that methyl group to homocysteine, it becomes the tetrahydrofolate. You can see that's what's left over and goes around. But to donate that methyl group, it needs to go through these enzymes. B12 is important. This regulates our hormone, which is an essential amino acid. And then we get S-adenosylmethionine. So in the functional medicine world, we tend to call this SAMe as the supplement, S-adenosylmethionine, and this is the universal methyl donor. So SAMe, or SAM, as I used to call it. So in the scientific world, we call it SAM. In the functional medicine world, when we're prescribing, we call it SAMe, the supplement. But S-adenosylmethionine is basically what provides all of these methyl groups, which is a carbon 3 hydrogen, these little methyl groups that stick onto either the DNA, hormones, neurotransmitters, whatever it may be, toxins, to help our body process these. So really the point of showing you this is just to understand that there are different types of folate. B12 is important in this particular case. This is a specific form of B12, methyl B12, that acts here. And there are a number of enzymes. And I'm not going to talk too much about the genetics as much as I love it, but just know that some of us have genetic variations in things like MTHFR, which means we need a bit more folate, or MTR, which the cofactor is vitamin B12, and they may need a bit more sort of methyl B12. So some of us genetically need a bit more of these things, but even if you don't do genetic testing, we just want to be aware that people are getting plenty of folate and B vitamins to make sure this pathway is running efficiently. So just to step back and explain a little bit more about methylation, as I said in the previous slide, it's a methyl group. When we say methylation, a methyl group is literally just this carbon and 3 hydrogens. And methylation is just the process of adding a methyl group onto something. So in this case, we've got one of the DNA bases, cytosine. We've got an enzyme, DNA methyltransferase. It picks up the methyl group. This, remember I said S-adenosylmethionine gives the methyl groups. It leaves S-adenyl homocysteine. So it picks up the methyl group and sticks it onto this cytosine, and we've got 5-methyl cytosine. So if it happens on the DNA, like we can see up the top here, sits on the DNA, it kind of acts like a switch, turning genes off and on, but it can be attached to, for example, adrenaline. So adrenaline we know is, involved in that fight or flight, that feeling of stress, anxiety. If someone's low in folate or Bs, having issues with methylation, they're not able to methylate that adrenaline or dopamine, noradrenaline, and break down our neurotransmitters, and they may stay more, have an exacerbated stress response, a heightened stress response. They may not be able to calm down because methylation is needed to inactivate those neurotransmitters, those catecholamines. In addition, sticking methyl groups onto estrogens helps us inactivate them and excrete them, arsenic, toxins, and it's also involved in the production of things like melatonin, creatine, etc. So for those of you who don't love the biochemistry as much as me, or you're pretty new to the methylation pathway, you can just think about it like a factory or the sort of production line. We have our food or supplements, our B vitamins, folate. We make methionine. We then make S-adenosylmethionine, And this is what enables those methyl groups. The SAM is there to donate those methyl groups either onto DNA or onto the proteins, neurotransmitters, toxins, hormones, etc. But just before I move on to the next section, I do want to remind you that folate and B vitamins, it's not just about methylation. So, you know, when I moved into the functional medicine space about 10 years ago, there was definitely a big focus on methylation. Whereas when I used to do research in a lab for 10 years, looking at these genes and measuring folate, homocysteine. I used to measure methyl groups on the mother's blood and comparing that to placental tissues. And I worked in the fertility space. A lot of people weren't talking about the importance for DNA synthesis and repair, or the DNA damage side. And that's something else I used to look at in the lab. So when we think about this metabolic pathway, yes, on the other side, there's this production of SAMe for methylation. But remember that folate and Bs also are needed to make one of the DNA bases. So DNA is made up of 4 nucleotides: adenine, thymine, guanine, and cytosine. And this U here, this stands for uracil. This is what sort of abbreviation for uracil. What happens is folate, actually this form of folate, 5,10-methylene, donates a methyl group. And when it sticks the methyl group onto uracil, this makes thymine, which is one of the 4 DNA bases, the T. So this is essential, again, when we're thinking about, you know, DNA replication in fertility, but also just day-to-day repair of DNA damage. You know, our cells are turning over. There are organs like our skin, our liver that are replicating or regenerating quite quickly. If people do have issues around DNA synthesis, that is going to, or repair, affect things like cancer and age-related conditions. So just to remind you, I've mentioned it, a few times, but when we're talking about methylation, which is driven by our folate and Bs, particularly B12, we know that they're important for turning genes off and on, for DNA and protein synthesis, so thinking about that production of methionine, for energy, for the metabolism of hormones, neurotransmitters, heavy metals, and other toxins. So it's important in detoxification as well, for fertility, as I've mentioned. And know that hyper or hypo, which tends to occur if there's low folate and B vitamins, you don't have enough methyl groups, particularly hypomethylation is linked with various health disorders, including mental health disorders such as schizophrenia, you know, neurological conditions like Alzheimer's and dementia, and also cancers. So let's talk about our food sources. So when it comes to folate, it's actually found in lots of different foods: green leafy vegetables, lentils, avocados, seeds, and nuts. So these are some examples, you know, of the amount of folate you can expect from certain foods. Obviously, it varies depending on where they're grown. Actually, the folate levels vary a lot. And this is part of the issue of people being low in folate, because folate's actually found in lots of foods. If people were eating a whole food diet and lots of fresh foods, in theory, they should be getting lots of folate and should not need to supplement. But the fact is, some people have got digestive issues, they're not absorbing. But the other thing is that folate is heat and light sensitive. So what that means is if you've picked your leafy greens, say, for example, in Australia, and they have then transported them across to the other side, they've sat in a truck, and then they've sat in the supermarket and they're under all the lights, the folate will break down. In addition, if you cook your greens, for example, your spinach, the folate breaks down as well. So it depends on the freshness, depends if things are cooked or not. So these are the recommendations here in Australia. It's slightly different in the Philippines. And when it comes to Hong Kong or China, I wasn't able to access your recommended dietary intake, the daily intake. Some countries just refer to the World Health Organization, but other countries such as Australia or the Philippines have their own specific value. So you can see in the Philippines, it's a little bit lower. So here we've got folate, here we've got B12. So if we're looking at adults, we can see it's 320 micrograms, whereas in Australia, they suggest 400. And then in pregnancy, which is down the bottom here, 520, and then lactating 450. So our requirements for folate definitely, as we all know, go up during pregnancy and breastfeeding, but a little bit lower than the Australian recommendations. And here we can see our B12 micrograms. The recommendation for the daily intake is 2, and again goes up slightly in pregnancy and breastfeeding. So when it comes to B12, we are predominantly going to get that from animal foods. So if you have a patient who's vegan or vegetarian, you definitely want to be thinking about their B12 intake. You can get some from mushrooms. You know, some vegetarians might be ovo-lacto, different things. They might be getting eggs, but generally the main sources are from our animal foods. So in Australia, it's a little bit more than in the Philippines. And again, this goes up in pregnancy and breastfeeding. The issue with B12, so we talked about the issues with folate. It's in lots of foods if people were eating real food, but obviously people are eating processed food or it's not as fresh. I mean, some of you might have a beautiful veggie garden. If you do, and depending on the soils, you could be getting nice amounts. But the thing with B12 as well is it's actually very difficult to absorb. So B12 is, if you look at the chemical structure, I should have put in a chemical structure. I think you get one of folate. But B12 is huge and it has this sort of cobalt rod through it. It's quite cool from a chemical composition, but it is big. It's harder to absorb. It requires intrinsic factor, you know, the right pH. There are transporters to get it across, transcobalamin 2 and other things like that. Sometimes people have SNPs. So there's a few steps. And if someone's got issues with the pH in their gut, or, you know, they're on protein pump inhibitors, anything like that, or digestive issues, that can be a problem as well. And as I was just alluding to, when it comes to food, because we want to get most of our nutrients from our food, the reality is there has just been such a change in the production of food in the last 100, particularly the last 50 years. So once upon a time, our foods were coming from nutrient-rich soil that were low in toxins. Now the food's processed, it's grown in soils that are not nearly as rich in their nutrients. We know that the microbes in the soil are impacted and they're adding fertilizers and chemicals. There's issues with food production, storage, you know, even with the animals and things like that, giving them hormones, antibiotics, etc. And unfortunately, there's a lot of confusion these days around what is healthy. So I've got some pictures here. You know, in Australia, we have, and I'm sure you have similar things in Hong Kong and the Philippines and over there in Asia and around, you know, we have things like, you know, star ratings for health, but sometimes there'll be a 5-star rating of a heavily processed food that is nothing like the original product. So there is a little bit of confusion around that. So we know that when it comes to folate and our Bs, we want to get as much as we can from our food, but there are issues with the food that we consume these days, also with digestion, some genetic things. But we want to determine if our patients need to get extra from the diet or from supplements. So you can do testing. So looking at folate levels, there are specific cutoffs to determine if someone is deficient. So less than 7 nanomole or 3 micrograms per litre, which is the, in the US, you might be the same over there. This is, you know, true deficiency. That's very low. I don't see that often, but that's very low. When it comes to red blood cell folate, there are different cutoffs, as you can see here. So this is the onset of folate depletion, beginning of basically the anemia, and then this is actually linked with anemia. So more recently, though, a single cutoff has been suggested, less than 317 nanomoles or 140 micrograms to designate deficiency. And when it comes to serum folate, that has also been increased. Some reference ranges have it a little bit higher based on the influence it has on homocysteine. So in addition to actually just looking at folate in the serum or red blood cells, you can, of course, do a full blood count or a complete blood count and find out if there are changes to the red blood cells or the blood cells, and that can indicate anemia, which can be linked to folate or B12 deficiency. So a high MCV suggests that the red blood cells are enlarged, or you could be looking for decreased hemoglobin or abnormal neutrophils, or even some changes, nuclear changes that are really associated with DNA damage. So low folate at the beginning, when I said about the importance of folate and our Bs, but specifically that form of folate to methylate uracil into thiamine. If someone's low in folate or Bs or having issues with methylation, you'll start to get uracil incorporated into the DNA strand, and that leads to chromosome breaks. And you can actually see it down the microscope. You can see these things called micronuclei, or if you're a medical doctor, I think they teach in medicine these how jolly bodies. So you can look at folate levels, you can look at a complete blood count, but also you can actually look at B12. So when it comes to looking at B12 levels, there's no internationally agreed definition or cutoffs for deficiency. So there's a range, as you can see here. In addition, the analytical methods are not standardized, and there can be influences such as changes in B12 carrier proteins like transcobalamin, which is what picks up B12, transports it through the blood to the cells. Changes in that can affect sort of what's known as the active B12. So here in Australia, if someone looks to be on the lower side, they'll also just automatically test this hollow transcobalamin, which is not the best, but a better marker of B12 than standard sort of serum total B12. But this, unless you're looking at true deficiency where it's really low, the results can be a bit deceiving, particularly if someone's, having supplements, even low dose supplements. It can look really, really high, and often that means they're not absorbing. I'm not sure if any of you see that, or you do a lot of this blood testing. If you do, let me know in the question time or make some comments, or we do have one chat. What are the clinical signs? Sorry, I'm just opening up the chat. I'm happy to do that throughout, by the way. And let me know if you've got any questions. What are the clinical signs of hyper or hypomethylation? So hyper or hypomethylation, if you're talking about signs, you'd be more thinking about effects in relation to, fatigue, maybe sort of energy balance, high estrogen, sort of looking at some of those things. But hypomethylation around gene expression, when you're thinking about things like cancer and things like that, that would be a lot trickier to determine. And hypomethylation, it's something that we don't understand completely, in the sense that you would expect that if someone is deficient in folate and B vitamins, that you would see you'd see hypomethylation globally, meaning sort of on all the cells. What we see when someone is deficient in B vitamins, or even had a very stressful event or been exposed to BPA, think plastics and toxins, they actually are hypomethylators. They strip our methyl groups. Alcohol causes a bit of hypomethylation. What we tend to see is some things get hypomethylated, but then other things get hyper. So we're still trying to understand this regulation. But just to answer that, Joan, because methylation affects so many different things in the body, from neurotransmitters, hormones, toxins, the clinical signs can be, quite wide and varied. So feel free to ask questions throughout. I'm very happy to answer. All right. So, here we go. So when it comes to, this is from the Australian guidelines for medical testing for doctors. This is what is considered the normal range here in Australia. So you can see the picomoles as well as picograms. And deficiency is generally thought of as under 200 picograms or less than 130 picomoles. However, I'm not sure if anyone wants to mention what your reference ranges are if you do a bit of testing. The reality is that that neurological symptoms, you know, signs of B12 deficiency, serious signs, clinical symptoms can be seen when B12 is, you know, higher than this. So we just definitely need to be cautious. And the reality is these cutoffs around anemia or, you know, suggested B12, they're not actually for optimal health. They're not promoting fertility. They're not promoting, you know, healthy brain function to reduce risk of Alzheimer's and dementia. These are deficiency to stop disease. So we definitely want to be thinking about higher levels than these cutoffs. So when it comes to actually Alzheimer's and dementia, Dr. Dale Bredesen is a leader in the world of research. He actually runs some Alzheimer's clinics over in the US, and he suggests that B12 should be between 500 to 1500 picograms. You can see it there in picomoles for optimal health and reducing risk of neurological conditions like Alzheimer's and dementia. And then my supervisor in relation to, and I should have the reference there, sorry, you can, I think that's in the notes of the slide. I can make sure you've got that if you want it, but Michael has looked at DNA damage. I have too. I've even tested it on myself, even looked at DNA damage after having alcohol and what it does to my cells. But levels that are greater than 300 picomoles is what he suggests to reduce the risk of DNA damage. And DNA damage is obviously associated with accelerated aging and a number of conditions. So homocysteine, so if you could only do one test in trying to determine if your patient is low in folate or Bs or have methylation issues, homocysteine is probably the best one to do. It's a very sensitive functional biomarker of folate and B12 status, although it can be affected by other things like lifestyle factors, renal insufficiency, or certain medications, but most of the time, you know, the direct influence on homocysteine levels is folate and B vitamins. And although there's no formal standardization, the measurement, the assays, the tests are a lot more accurate and precise compared to B12, and that is within places like Australia, but also globally. So if you're looking through the research and a study's done in the US or Europe or Asia, you can generally compare because, as I said, even though it's not formally standardized, it is sort of more comparable to the B12. So when it comes to reference ranges, what you want to look at for your patients are basically you don't want it to be over 13. That's considered abnormal and at risk for cardiovascular disease and other conditions. When it comes to reducing risk of cardiovascular disease, basically less than 10 micromole is desirable or suggested. And then this here is really based on, you know, me working in this space for the last 20 years, you know, 10 years in the fertility space, and then the last 10 years really just with a range of people from children, adults, you know, people with, you know, cognitive decline, around this 5 to 9. You don't want to be less than 5. Homocysteine is not actually bad. It's an intermediate amino acid, and we want to be able to have enough so that the body can either form methionine or go down the transsulfuration pathway to make glutathione and other amino acids. So you still want to have enough. And if people have, you know, deficiencies in homocysteine, that's going to have effects too. So we often talk about high levels having a negative impact on health, but low levels mean you don't have the building blocks for important amino acids. There is something that I like to do. It's very common with functional medicine practitioners in the US. And I do know that I think you've got Dutch testing and things over there in the Philippines and actually Hong Kong. You've got NutriSearch, so you can do these tests too. And methylmalonic acid, or you may even be able to just do it with your local GP. Methylmalonic acid through blood or urine is something that builds up when someone is low in B12. So you can use this. It's actually a much better marker than serum B12, a better functional marker of B12. And that can let you know if the homocysteine is due to B12, and if it's not that, it's likely to be the folate. And here are recommended ranges for optimal health. So I'm not giving you cutoffs, as in, you know, what the laboratory is telling you for disease. These are optimal ranges by Dale Bredesen, who's the leader in Alzheimer's, myself here from all the pregnancy research I've done, and Michael Fennick in reducing DNA damage. And just a little note, if you are testing, just reminding people that they need to fast. So often people forget to fast, and that can affect levels. And all of these ranges are based on fasting reference ranges. So we've talked about the importance of folate and B vitamins, what they do in the body, the things they influence, the foods they come from, ways that we can try to determine if someone's low. And there are other symptoms as well, clinical signs and symptoms that I'm sure most of you are aware of, aside from doing tests, you know, changes in the tongue, fatigue, if someone's pale, you know, pins and needles, there can be some neurological things. There are other signs of low folate and B vitamins. And even just talking to someone about their diet or doing a food diary and seeing if they are consuming these foods to find out if they're actually getting folate and B12. But this really leads us to supplements. And the reality is there are a lot of people that do require a boost in folate and B vitamins. So when it comes to supplements, a question that I'm asked by lots of practitioners is, you know, what is the difference in folates and B vitamins, because there are, or B12, because there are different forms. So folic acid is the synthetic form, and this is mainly found in fortified foods, as well as lots of supplements. You know, initially back in the 90s, you know, all of the supplements were folic acid, and this is because it's very stable. So that's good to have in a food or a supplement. The reality is, though, folic acid, it's not active. It needs to be converted. I showed you that metabolic pathway. It needs to be converted and go through a number of enzymes. So it has to go through this enzyme here, dihydrofolate reductase. And depending on the dose of folate, you know, hydrofolate reductase can become what we call saturated. So there's some emerging evidence. It's definitely not clear, but emerging evidence that possibly as low as 200 micrograms, probably more so 400 micrograms, this gets saturated, and it's not able to get into the pathway and absorb properly anyway. And what you'll get is this folic acid sort of in the serum. Like if you did your blood test, it might look like you got high levels, but it's not actually being metabolized and going through, particularly if you're having high doses, like 1,000 or 5,000 micrograms. So folic acid, as I said, is synthetic. It needs to be converted. I wouldn't say, some people say, I'd be interested in your feedback. I'll be cautious in my words, but some people think folic acid's quite dangerous. I'm not sure the sort of training that you've had, but in the functional medicine space, there is a lot of people that say, you know, you shouldn't have folic acid. Well, the reality is I did 10 years of research giving folic acid in the pregnancy health space in relation to late gestation complications, then fertility and miscarriage. And we saw benefits, not on its own, when it was with B12, you know, B6, like a B complex, because when you saw that pathway, you need all the Bs. And we did a lot of genetic testing, finding out if people require more or less. But the reality is it does work, but there is more and more evidence now saying that higher doses just don't get absorbed. And maybe that's sort of not so good, having high levels in the blood. And because of that, it is becoming more common to see other forms of folate. So folinic acid, it's not so popular, but folinic acid is one form. And the other one that we're seeing a lot more of that's becoming very common is 5-methyl tetrahydrofolate. So this is the predominant form that's found in our food. It's more natural. It's not as stable. So therefore, I mean, of course, what we're getting in the supplements is good quality and stable, but a little bit harder to sort of manufacture than something like folic acid. Folic acid you'll tend to find is a little bit cheaper just because it is easier to produce, whereas the 5-methyl is a little bit harder, but it is more natural. It's suggested that it's better at being absorbed. We don't really have any good studies comparing the absorption of folic acid and 5-methyl yet, but we do know that it's more natural and less likely to have those saturation effects that we might see with folic acid. So when it comes to dosages of folate, most of the guidelines, if you're looking at NIH or here in Australia, you know, throughout the world, if you're looking at Europe, America, here, the reality is most would say a maximum of around 1 milligram. And that is because, so, you know, 1,000 sort of micrograms. So the reason 1 milligram is suggested is to try to reduce the risk of masking B12 deficiency. Plus, if you do have high levels of folate and you've got low cofactors, it can start to muck up that balance in that methylation pathway. So even though I'm saying generally think of, you know, 1,000 micrograms or 1 milligram, the reality is some people will need higher doses. When it comes to patients that have had previous neural tube defects or spina bifida, or even developmental defects like cleft palate, you do want to think about 5,000 micrograms, so 5 milligrams. Even if someone has a BMI of over 30, they require more folate. And really bring in your skills, your holistic approach that we do in functional medicine to determine what is best. But as a general rule, 1 milligram is usually enough. And if you are thinking about higher doses, like 5 milligrams, because someone needs that, and by the way, some people really benefit on that, with that in relation to improving pregnancy health or even mental health conditions, you do want to make sure, though, that they have adequate B12, B6, B3, and B2, because otherwise folate can get stuck. If I was to go back and show you that folate pathway, I didn't just show you that to confuse you. It was sort of showing you that there are all these steps and these enzymes, and B6 is a cofactor, B12, B3 is in there on the homocysteine side, B2 is the cofactor for MTHFR. If you don't have these other Bs, the folate isn't going to move around that metabolic pathway as it should. So even though the folate's so important, it's the substrate. It picks up the methyl groups. It passes them around for DNA synthesis to make methionine, for S-adenosyl methionine, to, you know, convert homocysteine. You know, it's picking them up, but it will not move and pass them on if it doesn't have the enzymes and those B vitamin cofactors. Hopefully that makes sense to all of you. So as I mentioned with folic acid, Mark Lucock here in Australia, and there's another author in India, I can't think of her name, and others I think since then have shown that there's possibly a saturation effect with the folic acid. And basically it's because it is more stable, like structurally, chemically, if you looked at the chemical composition of folic acid, it's stronger, like being more stable, it's sort of got more bonds and it's harder to break down. So the body has to work harder, and these enzymes have a limited capacity to do that. So if you're overloading the system with something that's hard to convert, hard to break down, and you've got genetic variations or SNPs in certain enzymes that mean that the methylation pathway isn't as sort of fast as others, this can be an issue. But despite the concerns with folic acid, and I'd be interested to hear what people's feedback is, the reality is most of the evidence to date, we might start to see more in the next sort of 5 to 10 years, does support folic acid if we are talking about fertility, in the fertility space, as well as the mental health space, as well as the cardiovascular disease in reducing homocysteine, and the neurological space, because we do have a lot of trials with folic acid. So most of the research is on that. It's not to say that 5-methyl isn't better or as good, we just don't have an abundance of studies with the other forms yet. I see a little chat question. Yes, exactly, Joan. That is correct. Will it be safe to say that we give a complete B rather than giving high dose of any one of them? Yes. So occasionally, you know, I might give someone a single nutrient, you know, if it's rare. For example, I'm working with one person right now that's quite sensitive. and I'm giving her B12 first. But 95% of the time, or 90% of the time, I would give a B complex, or try to give, folate and B12 at least together. So this is just saying if you do genetic testing, and there are lots of SNPs picked up, you may want to think about the active forms of folate that the body absorbs and can use a little easier than the synthetic form. So when it comes to B12, we have cyanocobalamin, and this is the most common form in B12 supplements. However, it does contain a cyanide molecule. Now, the reality is one cyanide molecule is not toxic at all. Our bodies will, eliminate that. We've got a liver, we've got a gut, we have our bowels, we either excrete it through our bowels or, we will remove it. But the reality is it does require elimination. And for some people, they have, issues when it comes to detoxification. They might have sensitivities, a high toxic load, they react to certain things. In the space that I work in and you would all work in, we're generally looking for the best supplement, the best quality, the best form that is going to help our patients get well. And even though all the studies that show it's not toxic, I generally don't give cyanocobalamin. Again, every patient is different. I'm thinking of one right now. I actually just recommended a cyanocobalamin spray, but that is because she is so sensitive. I actually said to her, get the spray, and rather than have it orally, put it on her skin first. That's just because she just reacts to everything. Methyls, adenosyl's, she's had all these different Bs, but she's actually deficient in B, like we've done methylmalonic acid. She needs B vitamins. And yeah, I just wanted to give her something with a really low, tiny dose. So this happens to be a particular spray you can get in Australia. It's a very low dose. And I said, just put a tiny bit on your skin. But 99% of the time I'd be looking for hydroxo, adenosylc, or methyl. So these are more natural forms. Hydroxo is similar to cyanocobalamin in that it would need to be converted, because both cyano and hydroxo the cobalamin has to come off, and then it forms either adenosylc, which you can see here. So adenosylc is what actually goes into the mitochondria and helps with energy. And then we have methyl, which acts as a cofactor for methionine synthase, and is produced by methionine synthase reductase too. This is where we're thinking about the methylation pathway. So methylcobalamin, so B12 in that function of metabolizing homocysteine, supporting the production of SAMe for methylation throughout the body. So hydroxy is also been shown to have some antioxidant, anti-inflammatory properties. Unfortunately, in Australia, it's quite difficult to get the hydroxo. I don't know about you. I think in Hong Kong, you're quite lucky. You seem to get most things. I think the Philippines are a little bit like us. But we also don't have adenosylc here in Australia. It's not TGA approved. It is in New Zealand, everywhere else. I mean, of course, patients can buy it online themselves, but if we're wanting to follow our TGA guidelines here in Australia, this one hasn't gone through like what you would have in the Philippines. You've got the FDA, the USA has the FDA. You obviously want to, if you're a practitioner prescribing in a clinic and you're registered and trying to do things properly, you want supplements that are, registered. And here in Australia, we're quite behind, really behind. We do have the methyl though, and that's really popular. So when it comes to dosages, there was an article in the European Journal of Clinical Nutrition that talked about treating B12 deficiency. And it basically said that you should use, if someone is deficient, both the forms that are needed in the body, the methyl and the adenosylc. And then I've just added my little bit here to remind you, methylation, so DNA synthesis and methylation reactions, and then adenosylc, which is literally getting in the mitochondria to support that ATP energy production. So the paper states that this will address, both functions of B12 in the body, and the dosage is around 500 to 750 micrograms of each, which would mean a total of 1,000 to 1,500 micrograms. Now, unlike folate, when it gets too high, it could mask B12, deficiency, anemia, neurological problems, things like that. With B12, you tend to be able to go much higher. Like think about B12 shots or injections. So the clinic I used to work in Melbourne, we actually used to have a nurse that did all the B12 shots. So some people really do benefit from much higher doses. And here this is suggesting that sort of 1,000 to 1,500, because we're doing 500, 750 of each, methyl and adenosylcobalamin. So a total of 1,000 to 1,500. And I think about 1,000 micrograms of B12 for someone who needs it is good. And you may even go up to, much higher levels if you're just doing supplements. I don't work in a clinic anymore. I'm now online. So I don't have a nurse that can go off and do the B12 shots. But I might say, have a liquid with a higher dose, or a sublingual, which tends to be absorbed better, particularly if people have got gastrointestinal issues that can affect the B12 absorption. So this paper also talks about hydroxycobalamin and says that this is preferred or better for people that are smokers. So cigarettes actually contain cyanide, and smokers tend to build up levels of cyanide. So in that case, a smoker or anyone exposed to cyanide should not be having cyanocobalamin. So the hydroxycobalamin can be a better choice there. And this paper also concludes that the oral route is comparable to intramuscular. I'm not sure what you all think. I know that, some people having a B12 shot, they think you're amazing. They feel so good afterwards. I don't think I've seen such dramatic results in an improvement in energy and health from sort of oral. But I have, if people are having high doses and around liquids, and I said sublingual, they're more likely to notice that benefit. But you want to keep getting the B12 in. The issues with the shots, this is what I've seen, and you may have experienced it too. They might feel great after the first one or the second one, but then not sort of notice it for the following ones. But yeah, so when it comes to B12, thinking about the methyl or the adenosyl or the hydroxy, generally better than the cyanocobalamin. Again, thinking about the cofactors, if we're thinking about the total pathway, if you've got B12 and you've got folate, but they're low in B6 or B2, even things like zinc and iron, I haven't discussed these, but if you are giving some of these things, your patients don't seem to be responding, just know that in that metabolic pathway, iron is actually needed with MTR as well. Iron is actually needed to help pick up the homocysteine and stick it to that enzyme. So if someone's iron deficient, that can also affect that methylation pathway, the folate, B vitamin metabolic pathway. Zinc is also a factor. Vitamin C has also been shown to help support not just iron absorption, but folate absorption as well. And then occasionally, just a little sort of clinical pearl from me, if you do have someone with high homocysteine, you've given them a B complex or, some folate in Bs, and the homocysteine really isn't budging, it may be that choline could be the answer. So choline is also a methyl donor. Choline is really important for methylation, particularly in the liver and the kidneys, and that can be helpful as well. So just to sort of summarize this bit here, thinking about either testing, dietary assessments, or symptoms to determine if your patient needs supplements, there are different forms. There's the folic acid, which is the synthetic one, more stable but harder for the body to break down and absorb. We have folinic acid, not as popular, but that is another form. 5-methyl, hydroxy, and cyanocobalamin, both of these need to be converted to the active forms. The difference is cyano has a cyanide molecule, and if you've got a sensitive patient or someone with who's smoking or a high level of toxins, you may want to consider a different form if you're lucky enough to have the hydroxy or hydroxo. And adenosylcobalamin, think about this if your patient's got energy issues, fatigue, and methylcobalamin if you're thinking about specifically methylation. Maybe you've got a homocysteine or you're thinking more about, you know, hormone levels or managing stress, things like that. I see some things in the chat. Oh, what do you say to give complete? Yes, I've mentioned that one. For severe anemia, would you prescribe a B complex or just B12, and which form of B12? Okay, so for anemia, I would definitely do a B complex because it could be B12 and folate. And plus you want the other Bs, you know, supporting that whole pathway. And then also, you know, iron. I guess, you know, if they've got anemia, you've probably done some testing, you might know if it's iron deficiency, you know, or B12 deficiency. But I would definitely be giving the folate as well. And which B12 would I use for anemia? So, you know, we're not talking so much here. Well, you could, it depends on the patient. So I'm in Australia, so we have the methyl or the cyano. They're the two most popular ones. So I would be thinking about, you know, the methylated B12, the methylated folate, you know, your pyridoxine, P5P, along with your riboflavin, B2, things like that. However, if you're in Hong Kong or somewhere else, you could be using the adenosyl or the hydroxy. I will get to it, but ways to help determine whether people should have methyls over something like adenosylcobalamin or hydroxy 2 can be based on symptoms. So I'm jumping ahead, but you know, if someone is showing, you know, all that fatigue, you've got access to the adenosylcobalamin for ATP, then, you know, thinking about the methyl and adenosylcobalamin could be good. If they are a sensitive person, though, I do touch on it. I won't go into it here, but some people react to the methyls. I don't know if any practitioners have had that, where a patient has reacted to methyl groups, but you do need to be a little bit more cautious. But I've got a slide where I talk about it, and maybe we'll come to this one at the end again, and I can be a bit clearer, Denise, when I've gone through the rest of the slides. Recommended form of iron. I like either the iron bisglycinate, the glycinate form, nice and gentle on the tummy. Otherwise, if people are having some issues even around absorption or things like that, even the amino acid chelate, they would be the two forms of iron that I choose. All right, so who needs supplementation? Obviously, if people are showing signs or symptoms, they've got issues around, you know, full blood count, complete blood count, anemia, you know, homocysteine, other signs and symptoms, you can identify them. But the other thing to know is that there are certain populations that are at higher risk. So those who are in lower socioeconomic areas, but also the elderly, due to, you know, having trouble even absorbing particularly B12. And although the diets around the world are generally adequate in preventing clinical deficiency, remember I showed you those cutoffs, clinical deficiency, they are not really adequate when it comes to optimal health or fetal development. So if we're talking about reducing risk for neural tube defects, or reducing risk of Alzheimer's, or reducing DNA damage. So even though you might get, you know, a level in a reference range and it sort of doesn't look like they're deficient, are they really getting enough for optimal health? And from a functional medicine perspective, that's obviously what we're after. We're not just looking at, you know, being on the borderline of being anemic or having a disease. We want people to be thriving and well. So based on this, it is likely that a lot of diets, particularly those with, you know, higher processed foods, could be suboptimal. And really these issues around folate in Bs, but also particularly folate, are attributed to the poor stability. Remember I said that folate is heat and light sensitive, and incomplete bioavailability. So to do with absorption. So these are the unusual side effects that I was just touching on. So they usually occur with methylfolate, occasionally methyl B12. And I will say, honestly, I really haven't had any patients have this, but I talk about it because some patients have come to me after experiencing them, and it is something that we're aware of in the functional medicine space. So it is good to talk about it and know what to do, particularly if you're coming in with specific, you know, something like a methylfolate or a methylated B complex, and then your patient starts telling you I'm having certain reactions. So palpitations, anxiety, nausea, headaches, insomnia, these are things that can occur. And this can happen, again, going back to Joan, if you're having a complex, you may be less likely to experience it. I'm not sure about you, but when I moved into the integrative medicine world here, sort of moving from being a scientist, working in a lab and testing the genes and measuring folate levels and homocysteine in my pregnant population, and then moved into sort of more, clinical practice, a lot of people were giving the 5 milligrams of folate. It was very, very popular. So if someone's coming in particularly with the high levels, that's when you might see some of these symptoms. So it could be due to a folate trap. So if someone's low in Bs or other cofactors, folate gets stuck. So not only does that cause anemia, the reality is there are sort of feedback loops in that pathway. So when you get really high 5-methyl tetrahydrofolate, it will also slow down the production of sort of SAMe. So that can affect, methylation activities throughout the body. Methyl groups, now these are hypothetical reasons, but plausible things based on the knowledge of the pathway. Methyl groups also stimulate MT enzymes. What that means is methyltransferase, like COMT, catechol O methyltransferase. So COMT is what breaks down our neurotransmitters, specifically dopamine, noradrenaline, adrenaline. So there could be a link with giving methyls and that affecting catecholamine levels. In addition, folate contains these glutamic acid residues. So they're polyglutamates. So glutamine or glutamic acid or glutamate is actually excitatory, and that can stimulate neurological symptoms. So if you're giving someone a lot of folate, that can increase that pool of glutamate. In addition, tetrahydrofolate, one of the forms of folate, converts histidine into glutamic acid. Now, if the body's functioning normally, glutamine can be converted into, other amino acids. It's involved in glutathione production, could be leading into GABA, which is, calming. But in some people, they can be quite sensitive to glutamate, even think about things like MSG, and that is another plausible reason. So what to do? And I think the reason why I haven't seen so many reactions with my patients is I don't tend to go in with one nutrient, high dose, but start with a low dose and titrate up. Consume these supplements with food. So B vitamins should be had with food, generally at breakfast or lunch, not so much at night, because B12 does, affect the mitochondria and energy. Some people say they sleep well if they have B complex at night, but I tell people at breakfast or lunch with food. The other thing is vitamin B3 or niacin actually stimulates an enzyme that will use up methyl groups, also supports the breakdown of glutamate. And you may be aware of that if you've looked into these reactions. Most people will take B3 to stop that anxiety, palpitations, some of those things they're experiencing. B3 is usually the big one to stop it all, but B6 is also important because that helps push glutamate towards GABA. The other thing, just on my clinical observation, what I've seen in clinic when people have come in and told me they've reacted to B vitamins is these tend to be people that are very sensitive. This is not something that they react to and it's unusual. They are likely to react to foods, smells, other supplements, medications, and they tend to have a lot of gastrointestinal symptoms. So I think there's something going on, possibly even a link with dysbiosis, perhaps pathogenic, microbes in the gut. I mean, we know that some of the bacteria in the gut does produce, folate. So there could be an interaction with the gut. But yeah, definitely if someone is experiencing these things, aside from sort of coming in with niacin, thinking about working on their gut health and eliminating toxins, and definitely going low and slow with all supplements, not just the Bs. And just to reiterate, you don't need to be scared of your Bs, but these side effects, they're rare and usually only occur in sensitive people. And often they would already tell you that they've reacted to supplements, foods, things like that. But they tend to be the ones from a functional medicine perspective that come to us because mainstream medicine isn't working. You know, there are unusual things going on in their body, and we need to be aware of these more sensitive people. And in these cases, Denise, when you were talking about treating anemia, if someone had anemia, but they seemed like they were a sensitive person, even though the methyl B12, methylfolate would be good, I might start with a hydroxy or adenosylcobalamin. So if someone's sensitive, I'm going to be thinking about hydroxy. If I can't access it because I'm in Australia, you know, on the odd occasion, it might be cyano, but definitely the hydroxo or the adenosylcobalamin in those really sensitive patients is a good starting point. And then as they start to get better, you know, if they still need the methyl, you can move them on to methyl. Because the thing is, if someone needs methyl B12, sometimes they don't get that, like, I feel great. Because one thing with B vitamins, you know, most of our supplements, patients don't necessarily notice. You know, they may not notice even though their vitamin D is going up and some of their, you know, blood markers are better, or, you know, their overall health is better, but they don't notice the change. I mean, with B12, it is one of those supplements where sometimes people, particularly when they need it, and I've seen it a lot with the methyl in the right person, they notice a big improvement, whether it's around, you know, cognitive improvement, mood, probably more so, you know, mood and cognition. Oh, we've got questions. Any danger in giving these through IV drip infusion? Yeah, so we used to do this at the clinic. The doctors that I worked with, the GPs, used to recommend this. The nurse did that. Again, just thinking about dose. And again, if you, based on what we just talked about, you know, in that slide, if someone's super, super sensitive, you know, possibly don't go the methyls. Think about something like a hydroxy would be better to do in that case. Please repeat which iron with gastritis or digestive issues. I'd either do the bisglycinate. I used to like that one. That was my favorite, but I did have one patient, I'm not sure if anyone else has had it, say that they even felt funny with the glycinate form. I tend to think that's a bit nicer on the gut. And with her, I gave the amino acid chelate. That's probably the safest one. Again, talking about sensitive people, probably the amino acid chelate, which helps it get across. But otherwise, the bisglycinate is the one that I use the most and generally. Yeah, so Joan, that's interesting. Any experience on high dose niacin? I don't really prescribe high dose anything. You know, I've read and I've had patients come to me telling me, particularly even in the fertility space, around high dose niacin, not just nicotinamide, but you know, NAD and other forms being really, really good for fertility and things like that. Again, we're a bit limited here in Australia. We're behind. This is only one person, but I do have one patient I'm seeing at the moment that actually bought some high dose niacin online, and, you know, typical symptoms is what you read about, but definitely had all the niacin flush. She was very, very scared, you know, rash all down her back, felt tingly in her lips, things like that. So just being careful with the niacin, that's for sure. So yes, it can help if someone's possibly having some things with methylation, but you also want to be careful with niacin as well. Would you stay away? So interesting question, Denise. When I said that I've had some of the best, and I want to be cautious when I respond to this, because don't think, you know, this is not my, I don't usually get such amazing results, but I did have a little boy with autism that I gave methyl B12. And in this case, we did give, you know, one supplement at a time. He was a bit sensitive. And when I said earlier that some of the best results I've had are from the methyl, when someone needs the methyl, it really is. So in this particular case, this little boy who was nonverbal, was told he would never go to a mainstream school. We gave him methyl B12. We'd obviously done genetic testing, you know, all this other stuff. And I want to make it clear, his mum had done lots of work before he came to me. She was doing behavioural therapy, you know, speech therapy, all sorts of things. She'd taken out gluten from the diet, dairy. The mum was really trying hard. But I gave methyl B12, and he went home and picked up a pen, like never drew, tried to speak. And, we built on that. We ended up we went with the B12, then we did folate, B2, we got to a B complex. We put in some stuff to support detox, NAC, a few things. And he ended up at a mainstream school. He was 6, and I think he'd be 12 now. I haven't seen his mum in a few years. She's checking with me every year, but he was at a mainstream school. Other parents didn't know he had, autism. So I don't think you need to stay away from the methyls, even if someone's sensitive. In this case, we gave oral, don't usually give the kids the injection. But he'd had some other supplements, hadn't reacted to them. His mum had already taken him off inflammatory foods. He'd made a bit of progress. So I was comfortable to give the methyls, and it worked. Actually, at one point, I thought early on in this world, because I'd not worked with children with autism or ADD or ADHD, I'd really come from a fertility space. So I wasn't actually as comfortable working with these sort of families. I felt a bit out of my comfort zone, but the reality is the methylation, the detox, the genetics is the same. So I was doing genetic testing, looking for underlying drivers, whether that's methylation, detox, inflammation, etc., and then treating that way. And that's really how I treat, through the underlying pathways. And so at one point I thought that I could possibly cure autism. I thought it was just a methylation issue. But yeah, it didn't work for everyone. Everyone's different. And, after about 6 months or a year of treating, quite a few families in combination with a doctor that did a lot with autism, I did have one lady come back and tell me that her son didn't react well. She felt like he was, trying to climb the walls, and got quite anxious and behavioral stuff. So you do need to be cautious. But I definitely would not stay away. You just really need to think about what the patient would need. And if you are concerned, start with something that's less reactive, like a hydroxo or the hydroxoadenosol, like Pure's got the hydroxoadenosol combined. You could start with something like that. And if they're okay with that, then you go, all right, you haven't reacted. Let's, bring in methyl, but always start low. Like even with this little boy, you're starting at tiny doses and then waiting a few days and increasing. It might take you weeks, it might take you a month to get to a standard dose, but in these situations, low and slow, it's definitely not a race, and just assessing how the person responds. That was a long answer. I hope that it was helpful. All right, so in summary, we are basically made up of our genes. Some people require more folate and B vitamins, but it's also very much dependent on our environment. And the reality is our sources of food have changed. They're not as nutrient rich. They have more chemicals. If you're not eating organic, there can be pesticides, chemicals that will actually require, methylation activity, could deplete methylation to help detox. We're exposed to chemicals and toxins, medication and stress, and all of these things actually increase our requirement of our folate and B vitamins for all those methylation processes through the body. Even thinking about exposures to chemicals and toxins, endocrine disruptors, plastics, parabens, phthalates, all of these things that most of us know in a functional medicine space to avoid, but the reality is it's hard to. They're in the water, they're in some of our foods. So in summary, we know that folate and B vitamins are required throughout all stages of the life cycle. So if we're thinking about, preconception, someone is wanting to get pregnant, then we definitely, everyone knows how important, folate is, that's for sure. But it's more than just folate. You need to have the B12, the B6, the B2, the cofactors. So think about a B complex. Anyone dealing with stress, you need to break down those catecholamines. To do that, you need B vitamins to make methyl groups. Those that have got estrogen dominance or estrogen related disorders need to think about methylation support as well. and the elderly to reduce risk of cognitive decline. And I don't have it there, but definitely also managing cardiovascular health. So you can do dietary assessments or biochemical assessments or look at various symptoms to detect inadequacies and determine if you need to supplement. And it's important for practitioners to understand the functional differences. And I think if you know the differences, for example, adenosylcycobalamin energy, hydroxy, is going to be less likely to react. Methyl directly for methylation if they've got issues with homocysteine, or markers of methylation, even thinking about your MMA, the B12 markers. So there are those different forms. And then when it comes to folate, even though I've mentioned 3, folic acid, folinic, and methyl, the reality is most of the time you've just got your folic acid and methyl. The folinics not as popular. When it comes to dosages, generally a maximum of 1 milligram or higher in some particular cases, particularly around those that have had congenital malformations, or as I said, that higher BMI. And again, thinking about the B complex over folate on its own. So thank you. I am ready for questions. I've got one more here and then I'm going to ask you some questions too. Oh, thank you, Joan. I know I asked Denise. Denise wanted to say lovely words to me at the start. I said, don't even mention it because I'll probably cry, but my father passed and I just wasn't able to do the webinar last week. And I do appreciate all of you and, Denise and the team at Spectrum in the Philippines for moving it to this date, because even today I was a little bit concerned. Today's my first day getting back into the world, but I'm glad to be here with you all. So I have some questions if we have time to ask, and I think they're pretty easy, but it just will, I guess, allow you to know if you're clear on the sort of the advice around giving, folate and Bs. So the question is, and you can type it in the chat, or I don't mind if people want to take their microphone off and answer whatever you're more comfortable doing. What form of B12 would you suggest for someone who is suffering with chronic fatigue or really sort of energy issues? I hear some feedback there.
Joan, did you have something to say? You have a little bit of a feedback on your microphone.
Yeah, hello?
Hello?
Adeno? Yeah, the adeno form of B12.
Exactly, yeah. So definitely if we're thinking about chronic fatigue, the adeno form, the adenosyl, that is basically going to go straight to the mitochondria, helping with ATP. So what form of B12 would you suggest for someone who is smoking cigarettes or has a high chemical load? A high chemical load because you've maybe done a GPL tox or they've got chemical sensitivities. Oh, thank you, Dolly. Yes, adenosyl and then hydroxo. Yes, thank you. That's correct. And I've already said the answer. There we go. So that's hydroxo. And even though I'm trying to make these clear, the reality is if someone had chronic fatigue, you could still give a hydroxy and an adenosyl as well. But we're just sort of highlighting the main functional differences between these here. So if you needed to support methylation, what supplements would you suggest? If anyone wants to pop it in the chat or tell me. It's possibly too easy, but so thinking about methylation, we would be thinking about the 5-methyl tetrahydrofolate, that methylcobalamin, and then along with, if you think they've got a good diet, they're taking in the other Bs, you might just be thinking about folate and Bs, or a B complex that then has, B6, whether that's pyridoxine or P5P, your niacin, your B3, vitamin B1, the whole range. So in general, what is a safe dose of folate? And not only am I happy to get your answers here, feel free if you wanted to question that. I know some people, you know, I've been to conferences where I've had people sort of tell me other levels that they're, 1 milligram, 1,000 micrograms. And would you agree? I mean, you're all experienced practitioners as well. Is this similar to the way you practice, or do some of you give higher doses? You know, in general, if I'm thinking about folate, just as a general rule, depending on what's in, you know, the complex, Pure's obviously got a few complexes. They've got their main B complex that's sort of got lower levels of folate, and it's about 400 micrograms, which is fine, because you do want people to be having a good diet as well. But then they've got the Pure Genomics one, which has got higher, 1,000 micrograms of folate, and the B12. And if I am doing genetic testing, I might be giving the higher one. What should you consider when you're giving high dose folate? I think, Joan, you've already answered that. You asked in, you know, suggesting the B complex. And then when it comes to B12, you know, depending on the person, because I do see quite good results with B12, as in people feeling much better, cognitive, you know, improvements, energy improvements, you know, mood. I am comfortable going up to, you know, and there's some of the single doses with Pure. You might even think about adding on an additional B12, you know, up to, you know, even 5,000 micrograms. I don't know if anyone here gives B12 shots. If you give high dose B12 shots, that was common, as I said, when I moved into the medical practice, or higher dose folate. Does anyone give high dose B12 or the B12 injections? Oh, and I've lost the chat. Oh, there we go. You've had them. How did you feel, Denise, did you notice a difference?
Yeah, so I think it's very similar to what you said, where you feel the difference at the onset. And then after that, I don't know whether my body got used to it, or if I needed, you know, a different B vitamin, but I did feel it at the onset. Yeah.
I think with supplements too, particularly if you're starting, you know, if your patient's sensitive or you're a bit concerned, or it's a child and you want to titrate up, there's not going to be that, oh my goodness, you know, that big change straight away. But it does come, you know, it might just take, you know, a month or 3 months. And then people don't tend to notice the difference when it happens slowly over time. One thing that I do with my patients, it's not compulsory, they don't have to do it, but I get everyone to fill in a symptom tracker, like a questionnaire, before they see me. And I love this symptom tracker or symptom questionnaire, because sometimes people will say, I forgot that I was waking up in the night with that thumb pain, or I forgot about that. People just forget these little things, and then they'll be like, oh my goodness, there's all these improvements. They're like, I kind of knew I felt better, but there are all these little things that are annoying them, but we just sort of go on day to day. So one thing, if you don't already do it, it definitely works for me, is, you know, keeping if your patients are happy to do it, it's a quick online form of symptoms every time they come to see you, because then you can actually compare, like it will add up the, you know, certain things. So you can be looking at, you know, neurological stuff, or energy, or cardiovascular related things, eye related things, etc. So I really enjoy speaking to you all. I'm grateful to be back. Thank you all for being patient, and we are hoping in 2023 that I'll be able to hug you all in person. So how about using probiotics to increase B vitamins? Yes, so I mentioned that folate is produced by, so it is E. coli actually that produces folate, but there are other microbes, bacteria, that produce B12 as well. So it is possible that if you were having probiotics, you could be stimulating the growth of certain species that actually produce and synthesize B vitamins. The other thing is, just by improving gut health, you could be then improving the absorption, which is obviously an issue for a lot of people with digestive disorders. And on that, when thinking about supplementing, if someone does have a lot of, pain, bloating, digestive issues, constipation, diarrhea, all these kind of things, if you have access to it, thinking about the sublingual form, as well as the liquids that, you can even hold in your mouth and start to be absorbed through the mucosal membranes, and then you're not reliant on sort of the gastrointestinal absorption as much.